I try to give you a glimpse of some highlights of the EASL clinical practice guideline that has been developed to address the issue of the liver disease caused by occupational exposure to chemicals, which is quite a novelty to us. It's quite an innovative approach for hepatologists. These are my conflicts. Why doing so? Because the EASL Foundation has developed interest in the area of awareness campaign to address shedding new light on this new scenario of liver disease caused by occupational exposure. This has many implications in research, science, but also, if you wish, in the campaign of fundraising to address outside the borders of the classical pharma companies. Why doing so? Quite easy, because liver toxicity is the most common organ injury due to exposure, occupational exposure, environmental exposure to industrial chemicals, and there are no recommendations available from liver societies so far. Like drug-induced liver injury, which is the backbone for us, has been the backbone for us to elaborate on this, and ethanol, occupational liver disease recapitulates, if you wish, an injury which is linked to gene-environment interaction. Perhaps this is an area which microbiome is still innocent, but sooner or later we might have also this coming true. As May 2011, more than 60 million unique chemicals has been registered with the Chemical Habitat Survey Registry, and all of these are potentially liver toxic, or the vast majority of them. 1/3 of the 677 most common workplace chemicals reported in the National Institute of Occupational Safety and Health Pocket Guide, which is something that provides registry on this, are associated with hepatotoxicity. Unfortunately, we are devoid of data, robust data, on prevalence of occupational liver disease, and this is the additional aim for working in this area. To this end, the EASL decided to set up a committee of experts that I personally was pleased to chair, composed by an epidemiologist, very well-known cancer area, by a fine expert in occupational diseases. Everyone knows Professor Lucina from Malaga in the area of pharmacology, and Dili. Christoph Stoth is a pharmacist in Ghent. Valérie Paradis, a fine pathologist in Clichy. And of course, Phil Newsom is an expert in metabolic liver disease, was representing Birmingham. We use the Oxford grading of evidence system to grade evidence, and I can anticipate that there are no trials, there are no robust evidence-based data available. Most of our work was based on expert opinion, of course, and thorough scrutiny of the available literature. And more or less, we followed the parameters of the drug-induced liver injury to qualify liver injuries caused by occupational exposure. That said, what would the mission of these guidelines are? The scope is obvious, to focus on occupational chemical-induced liver injuries, and we just did not cover viral infection in healthcare workers or environmental pollutants. So we focus on exposure to chemicals. And the aim is to provide a standardized nomenclature, definitions, and classification of the type of liver injuries based in part of the criteria used for DILI. And I wish to remind you that last year, EASL provided also the updated guidelines, practice guidelines on DILI. And of course, to increase awareness of this special issue within the medical community, because we were not very confident, we were not very used to deal with this, and to improve recognition and management of the affected patients in a very standardized manner. At least this was our mission. I focus on 3 aspects because you have to read them. That cannot be covered in 20 or 15 minutes. So I selected 3 topics. One are the challenges that hepatology has in obtaining the occupational history and making a diagnosis, the clinical pathological spectrum of the disease caused by professional exposure to chemicals, and in the end, liver tumors associated with exposure, which is most important in my opinion. Okay, why hepatologists are unfit to collect the occupational history? Easy. Because you need to collect a chronological summary of all work activities and their duration, and we know nothing about this. You have also to collect a detailed description of the workplace, the job, and of a typical working day, and we are not experts at all. The need to have an inventory of all chemicals that are present and how they are used. Details of any measure that is in place to limit chemical exposure, such as workplace ventilation, nature protective measures are taken here and there, and we know nothing about it. Inquiring if programs of industrial hygiene, biological monitoring, and medical surveillance or have been in place and retrieve the result. And we know nothing about this as well. Also, we have to inquire as to whether co-workers have similar symptoms, just to set up a kind of epidemiological survey and assign to those of the patients with suspected old. Inquire if compensation procedures have been undertaken, because this has not only medical legal, but is part of the Sentinel system. And results are available. And exposure to chemicals other than those present at workplaces associated, for instance, with environmental air pollution habits, recreation habits, and others should be realized. So this explains why we are not fit to deal with this. So the recommendation by EASL was set up a multidisciplinary team in which, of course, a pathologist together with pathologists, toxicologists, and epidemiologists are in place, but the pivotal role of the occupational medicine physician should be recognized. That's important. On the top of this, the second point that makes recognition of liver disease caused by occupational exposure difficult to us, as pathologists, is that the diagnosis of old remains really challenging. Why? First of all, there are no predictive models of human toxicity, so we are not helped by science. Mimics all types of liver injury, from hepatitis, cholestasis, finish with tumors. Occupational liver disease is a diagnosis of exclusion. So you have to know everything about liver disease to be sure of a final diagnosis. And unfortunately, we are not going to be helped by any biomarker. They do not exist. And in the end, you have to disentangle cases that are due to the rarely occurring acute exposure versus chronic subliminal exposure. But what's really important was you have identified that that chemical might be responsible, that chemical has been taken up for several days or months. You have to be sure that there is enough level of exposure that grants for pathogenic role of that chemicals in the occupational liver disease you are going to diagnose. So all these things makes diagnosis cumbersome, at least to a pathologist. The second point I wish to address is the clinical pathological spectrum, to understand what we are dealing with. And then to walk you in this scenario, I'm presenting this that comes not exactly from occupational disease, but recapitulates all the potential factors that are involved in causing and modifying the effect of exposure in a worker. The chemicals that are potentially toxic to the liver can get into contact with the worker through the body surface, air, and water, no question about it. And here you see that there are a number of situations that might have as risk modifiers that are related to lifestyle, location, and also, if you wish, psychosocial factors. In the end, there are host factors that really matters, like aging, metabolism, the co-presence of inflammatory disease, oxidative stress, hormone, microbiome. But what matters here, and was not covered in this specific paper, which I repeating is not meant to address the occupational diseases, was sex. The fat to muscle ratio in women is higher than in men, and the vast majority of chemicals that can hurt the liver are in fact liposoluble. So women are considered at greater risk of developing occupational liver disease than men, for this simple reason. What is the clinical spectrum, clinical pathological spectrum of the liver disease associated with exposures to chemicals? Okay, there are some chemicals like solvents here, including gas or classical chemicals, vinyl chloride, dimethylformamide, trichloroethylene, tetrachlorocarbide, that might injure hepatocyte, just causing hepatitis, viral hepatitis-like lesions, cholestasis, steatosis, Toxic unassociated steatohepatitis, we will spend more time on this, that's important, and neoplasia, particularly vascular, but also hepatocellular carcinoma. Dimethylformamide, which is highly represented in many chemical processes, you can also have in the landfill leachate, as a pollutant of the waters here and there, may affect cholangiocytes, and there are forms of sclerosing cholangitis has been associated with this kind of exposure. Vinyl chloride. The vinyl chloride is a gas that needs to be polymerized to produce plastic. And in your bag, you have a warning. This is a bag free of polyvinyl chloride. To tell you how impactful has been vinyl chloride in the manufacturing of everything that we are going to use, but also was the very first example of occupational disease that the community of scientists and experts were able to take care of, and today is no longer a threat that used to be, as it used to be in the past decades. Vinyl chloride is a gas that is being polymerized to manufacture plastics, and in this process there are persons that have been heavily exposed to this gas developing injuries at endothelial levels that goes from very easy, simple, let's say mechanical diseases like sinusoidal obstruction to potentially preneoplastic changes like pileosis hepatos to frank cancer like epithelioid hemangioendothelioma and angiosarcoma. Professor Hans Popper studied this thoroughly in the past decades, and he was able to demonstrate at experimental level together with other scientists in Italy and in Europe, in America, that the exposure to this gas in the experimental animal is going to produce a number of stepwise lesions that in the end are precursors to angiosarcoma of the liver that we will discuss later on, like a hyperfocus of hyperplasia, pileosis itself, and also, in the end, vinyl chloride is a two-phase chemical substance. On one side, it is being metabolized like alcohol, so it might cause a number of inflammatory changes in the liver, like TASH, we'll discuss this. And on the other side, it is a highly mutagenic and genotoxic and might cause cancer, and we see this. And also, vinyl chloride has the properties to stimulate the stellate cells, so Professor Pinzani is here. And as a matter of fact, periportal fibrosis was one of the first damage of the liver that has been identified in workers exposed to vinyl chloride, causing liver stiffness. Today it would be easy to diagnose this with FibroScan, of course, but causing liver stiffness resulted in portal hypertension in non-cirrhotic liver. And on top of this, there are data suggesting that extensive fibrosis caused by this gas might end up in some patients with mimicking, to some extent, cirrhosis. We'll see this. Acute occupational liver disease rarely occurs because there are a number of systems to prevent it. But it has been clearly related to a number of liver damage, going from, let's say, hepatitis-like lesion, to cholestatic, which is always mixed, hepatitis, blood cholestasis, TAFL-D, toxic unassociated, exactly like NAFLD, and the vascular that goes from benign to malignant. And here is the list of the toxicant, so vapors, chemicals that can be inhaled or chemicals that can be absorbed to the skin, and metals like arsenic, mercury, and the likes. Chronic, not malignant, occupational liver disease are there, and perhaps there might be an excess of cirrhosis in workers exposed to vinyl chloride. These are particularly the reactor cleaners, those that were asked to clean up the autoclaves after the process of polymerization of vinyl chloride has taken place. But there are also, and other workers, the risk of cirrhosis has been identified in other workers. Heterogeneous bar staff, both sexes, male, seafarers, caterers, cooks, kitchen, but there, if you look carefully, other cofactors are working, like alcohol above all. And there is no consistent association with other exposures. So all these, all the literature regarding occupational liver disease is heavily polluted by cofactors, comorbidities that were not properly accounted for. Alcohol, viral hepatitis, diabetes, overweight. So this makes quite unlikely that cirrhosis is, generally speaking, an important end product of professional exposure to many chemicals. What matters is the toxicant-associated steatohepatitis, a definition that has been elaborated in the 2000. This is classically similar to what we know about NASH and NAFLD. It might be insidious with perfectly normal ALT over time. Here you have a list of the substance, gas, and metals that are associated with the TASH with or without elevation in enzymes, in transaminases. And this is a study done in Brazil, 3 groups of individuals, exposure to chemicals, vinyl chloride and the likes, exposure plus metabolic condition, no exposure but metabolic condition. You see here in red, there is marked the risk of steatohepatitis and also cholestasis, which is associated with exposure. When exposure is not present, there might be some level of metabolic condition-related liver alteration, but not fibrosis as much as here, and not cholestasis as much as here. This was by Cotrim. Another study done in America, liver biopsy in 25 patients heavily exposed to vinyl chloride. There was a high rate of fibrosis, hemangiosarcoma, and interestingly enough, the patients with chemical exposure had a number of alterations in the cytokine and antioxidant activity that are considered to represent the second phase in the classical model of NAFLD moving to NASH at experimental level. The third point, liver tumors. And hepatic angiosarcoma is a terrible disease. It means dismal prognosis. It is associated with liver disease, men over women, of course, differential diagnosis with epithelioid hemangioma and hemangiosarcoma, epithelioid-like, Kaposi, and other benign disease. The risk factors, vinyl chloride, thoratrust, metals like arsenic, a number, but also chronic liver disease. Angiosarcoma should be differentiated by hepatic epithelioid mesothelioma without background liver disease. Very heterogeneous in its clinical presentation from no symptoms to highly symptomatic, differential diagnosis against angiosarcoma, Kaposi, metastasis, veno-occlusive disease, but Chiari. And risk factors are multiple here. Vinyl chloride and asbestos, good, but also viral hepatitis, alcohol, and oral contraceptives. This is the largest studies done in America because in 1970, angiosarcoma was identified as a risk as a complication of exposure to vinyl chloride in these Goodrich plants in Virginia, and also civil investigated everywhere in the world. And this is the largest study, approximately 10,000 workers followed up for years and years. You see, virtually we have the cause of death in everyone, and there's people has been followed up for an average of 28 years, and this is the result. If you look here, square in red, cancer of the liver, including HCC, cholangio, but of course angiosarcoma. The standardized mortality ratio was significantly higher for this tumor of the liver. Sorry, this thing's where it goes here. You see here? Okay, but of course there is a confounding here that there was no autopsy available, there were no liver biopsies or were retrieved retrospectively, so there must be some misclassification between angiosarcoma and hepatocellular carcinoma. However, when they try to disentangle the diagnosis based on this retrospective criteria, there was a clear-cut relationship between the level of exposure here, you see, in both angiosarcoma and the hepatocellular carcinoma. And more recently, hepatocellular carcinoma has been linked to the risk of exposure by a study done in Padua, Maria Guido. You see, there was a patient that developed a liver cell hepatocellular carcinoma in 2009, and in 2012 he developed angiosarcoma and died of it. In 2009, hepatocellular carcinoma was associated to TASH, so a kind of a NASH, And these patients have no other risk factor for NASH nor alcohol here and there. Interestingly enough, the classical point mutation of KRAS mutation at the chromosome 12 was identified in the angiosarcoma, but not in the liver, in the hepatocellular carcinoma. So to my understanding, I still believe that hepatocellular carcinoma might be more related to TASH, NAFLD-like syndrome, rather than to vinyl chloride. But this is a piece of evidence that makes hepatocellular carcinoma likely to be associated. So this is what the practical guideline state in the end, that for liver malignancy, vinyl chloride monomer might cause angiosarcoma of the liver, and possible and also is associated to development of HCC. There are controversial associations with liver cancer for the rest of the chemics, and particularly trichloroethylene and other chlorinated pesticides like dioxin here and there. Open, completely open. And this is the recommendation we did. So patients who in the past, workers, sorry, in the past who have been heavily exposed to vinyl chloride should undergo surveillance. The obvious question is, you put these patients under surveillance, but angiosarcoma of the liver is a terrible disease that kills almost 100% of the patient. But you might be lucky enough to pick up hepatocellular carcinoma if this is the case, and then you have a number of life-saving approaches to the liver. And I'm almost finished to tell you what to do to make a firm diagnosis of occupational liver disease. Whenever you identify an overt liver injury and you suspect an occupational liver disease, you have to define the specific phenotype. And of course, you have to think about the possibility that it is an acute liver injury, a TASH, there is fibrosis, perhaps cirrhosis, a vascular disease, or a tumor. Then you move on and you try to identify the hepatotoxin. Of course, you have to gather the occupational history and also to assess the exposure, important, intensity, and duration. Then you go down to the etiological assessment according to the clinical context. We are hepatologists, we can do that. And then you make the diagnosis. But at this point, you have to take care of a number of confounders, viral hepatitis, biliary obstruction, alcohol, here and there, DILI. And perhaps you might be required to use a liver biopsy to define a correct diagnosis. And in the end, you have to rule out the other confounding factors. Most of the workers are overweight. 12% have diabetes, 15% have arterial hypertension. So there is a lot of work to do on a clinical ground. And in the end, you will have also to search for the multi-organ involvement, because some of these drugs might act through a dose-dependent or a dose-independent modality, and they might be also associated to multi-organ failure. So yeah, you come to manage your patient. And last but not the least, the take-home message. Collecting the occupational history is crucial. Patients must be assessed by a multidisciplinary team, as we said. Acute liver disease rarely occurs, and compared to chronic liver injury, which is the rule. And there are many sensitizing cofactors, diabetes, overweight, here and there. Angiosarcoma of the liver is clearly associated with high exposure to vinyl chloride. It was a problem in the past, and perhaps it is still in some areas that are developing, no question. Hepatocellular carcinoma is possible, not sure, it's possible. Cirrhosis, we think, unlikely. Hepatitis and cholestasis are the dominant occupational lesion. We did not cover that, you might read it. Often obscured by comorbidities, such as alcohol, it is an issue, and metabolic steatohepatitis. The unmet needs, availability of specific tests of toxicity. Thank you for your attention.